And we will proceed on to Melissa Wilson, who's our lead PA in the melanoma program and has been a compatriot of mine for 22 or maybe 23 years now. And so welcome. No, you're obviously very young.
Thank you.
Some of us are old.
Okay. Hi, everyone. So I wear a lot of hats. Some of you might know me because I also am I am the Ask an Expert for AIM at Melanoma. So if patients contact that line, I'm the person that you get. So I've been with Dr. Kirkwood my entire career. It's an honor and privilege to have been through all of these clinical trials to see a lot of the medicines that we're now using come to fruition and seeing patients that have survival. So I just always feel very blessed to have been on that journey. So what I'm going to talk about today is really exciting. So as you all know, and it's already been alluded, we have the first cellular therapy in melanoma, which is TIL therapy or tumor-infiltrating lymphocyte therapy, also known as Lifacil by Iovance. We're going to just talk a little bit about what is this therapy? What does it mean from a patient perspective? Oops, wrong button. Okay, so I guess where to start is what is TIL therapy? So TIL therapy is a little bit different from what we generally know from immunotherapy. So immunotherapy, historically the checkpoint inhibitors, is where you use a drug to influence the immune system to do something else. So we're engaging the immune system to create a response in another place. The difference is TIL therapy is actually a cellular product that uses and administers actual immune cells that are unique to the patient in order to cause activation of the immune system. So one of the more important players in that process are the lymphocytes. So we're actually using lymphocytes that have somehow managed to make it to the tumor, which is great because now they're recognizing and mingling with those tumor cells, and they take them out of the patient where they harvest a tumor. They get sent to a lab, and we grow lots more of those tumor-specific lymphocytes. And then after a little bit of lymphodepletion, because we have to get rid of the lymphocytes that don't have that instruction to kill the tumor, then they get reinfused back into the patient. They get boosted with a drug that's called IL-2. And then once the patient recovers, they get to go home. So we'll talk about, this is like the general overview of what TIL therapy is. So how well does this work? So I got this actually right off of the Iovance website. The overall response rate was about 32%. I will tell you though that this is in multiple lines of therapy. So these are patients that have failed conventional standard of care drugs. And so even though a patient might look at this from a perspective of, 32%, that's not that high. This is a patient that has actually had multiple treatments that have not already worked for them. So this is actually quite a great response rate for a patient in that type of situation. I will tell you, when I first started working in melanoma, those response rates for patients that had made it past the first or second line of therapy were like in the teens or even worse. So, having this response rate for patients in a refractory setting is quite impressive. Of that 32%, 27% had a partial response, which means that part of their tumor went away, but maybe not completely away. And they had 4% of patients with a complete response. And this amazing outcome is what led eventually to the FDA approval. One of the questions that we get a lot in clinic is, how long does this take to work? On average, we start to see responses in about 6 weeks. However, that can take a little bit longer in some patients. It can happen a lot sooner in some patients. One of the things that I wanted to, and this is something that we tell our patients is, they think, oh gosh, I'm going to be in the hospital for a couple of weeks. What in the heck should I do for that? We try to prepare them for their stay in the hospital. So a couple of tips that we say is, make sure that you bring some activities to do while you're there. You're going to be there a while. Days are long. Now people are going to be coming in and out of your room, but you certainly want to bring some activities to stay entertained while you're in the hospital. You also want to make yourself feel as comfortable as possible. Bring your favorite blanket, bring a pillow, bring, whatever it is that makes you feel most comfortable. Patients always ask about what they can wear in the hospital because hospital gowns are terrible. So I just always encourage patients to ask, what are the policies for wearing pajamas or loungewear? Everything has to be accessible. So like your chest still has to be accessible in case you need an EKG or they need to access a line. They need to be able to get to your arms so they can put IVs in. So just making sure that like you're being cognizant of the things that you have and bring with you. You also want to make sure that you share your caregiver's information. A caregiver in this process is extremely important. You want to know how to get a hold of them. So make sure that you let all of the care team members know how they get a hold of your caregiver when they're not there. And obviously ask for help. Everyone from the medical assistants, the technicians, up to the physicians are all there to help you. So you want to make sure that you ask for help. So how do we find out who is eligible for TIL therapy? So this is a little bit complicated because there are certain things that are, definite criteria, and there are things that are sort of subjective to the patient. So, some of the things that we have to keep in mind is that you have to have failed other standard of care therapies. So this is, while there are trials being conducted and things are in process for using this as a frontline agent, the actual FDA approval is not used for first line. So you have to know that the patient has failed conventional checkpoint inhibitor therapy or BRAF MEK inhibitors if they are BRAF mutated as well. You have to have a tumor that is amenable to resect. So there's a slide where we talk about what the tumor requirements are, but you have to have at least a tumor that can be resected and the other tumors to measure. And then there's some more subjective things like, is the patient well enough to wait for the TIL manufacturing? That process does take anywhere from 22 to 60 days. And so when you're looking at a patient for TIL therapy, you don't necessarily want to pick a patient that is not doing well, that may be a little bit more sick. You really need to know that they're going to make it to their transfer. The other thing that we want to make sure of is that the patient is well enough. So there's a slew of testing that we go through, which we'll get to on the next slide, to really assess whether or not from a medical standpoint, their heart and lungs and brain and everything are in a safe place. So this is a little bit about that. So we want to assess their tolerance to not only the lymphodepletion, because that involves chemotherapy, but also the interleukin-2, because that process has a lot of adverse events in the moment. And so we want to just make sure that they're safe. So some tests that we do for that are pulmonary function tests, an echocardiogram where they look at the pump function of your heart. They'll do some lab work. We'll do some lab work to look at organ function. One of the really important organs in both the chemotherapy process, but also the IL-2 process is kidney function. So in patients that might have difficulty clearing fluids because the IL-2 can cause a lot of third spacing where you get fluid in your hands and feet and brain and skin. It can cause a lot of low blood pressure. We just need to really make sure that someone can really clear the fluids. The other thing that we take a look at is brain metastases. So while TIL therapy allows for patients with brain metastases, we do find that these need to be treated. So with radiation therapy or resection, they need to be very stable. A lot of this comes from the toxicity of the IL-2 as well. It can cause a lot of swelling and cerebral edema. So we want to make sure that we really have a patient in as stable a process as possible. Some other things are that we shouldn't be on more than 10 milligrams a day of prednisone, as that is a immunosuppressant. So we don't want to do that when we're trying to engage the immune system. We think about things like live vaccines, and the recommendation is that there shouldn't be any live or attenuated vaccines either 28 days prior to starting the lymphodepletion or 3 months after the last dose of IL-2. The other thing that we take into consideration is bridging therapy. So because we resect the tumor and then we have to wait for that product to be made, we have to think about like, how do we make it through that maybe month or so in between. And so you look at bridging therapy. If someone is BRAF mutated, we use that a lot of times. We really want to think about it because we don't want to give a patient a drug that maybe causes some side effects that then we have to put them on prednisone for, or will make them more sick. Here is a little bit about the tumor requirements. A tumor, in order to be harvested for TILs, has to be at least 1.5 centimeters, up to 4 centimeters. A lot of tumors that are bigger than 4 centimeters have a lot of necrosis because they're so big that their blood supply isn't enough. And so they start to kind of die. And when that happens, there's not as great of a lymphocyte response in those types of tumors. You can also, if you don't have a tumor that is 1.5 centimeters, you can take a few little smaller lesions. That will be helpful to get to that sort of total volume. Once the tumor is harvested, they take away all the necrotic tissue because they don't need that and it's not helpful. And then it's sent away to the lab. Again, the average time to get the tissue ready for infusion is about 34 days. It's also preferred that the tumor that is harvested has not been injected or radiated previously because, again, that lymphocyte count and having those T cells in the tumor is what is the most important thing for this product. So once we harvest the tumor, about 7 days prior to the TIL infusion, the patient will be either admitted into the hospital, or there are actually some institutions that are giving the chemotherapy outpatient. Ours is not one of them. We do our inpatient chemotherapy as part of the admission for the TIL infusion. The most common chemotherapies that are used are fludarabine and cyclophosphamide. The chemotherapy can last anywhere from 5 to 7 days, depending on how fast your lymphocytes get depleted. One of the things to look for or to expect as a patient is that they are going to want central access. And what that means is either a PICC line, which goes in your arm, or a catheter that is bored underneath the chest into the central circulation. That's something that can be removed or will be removed most times whenever you are finished with the TIL infusion. And that's something that sometimes we forget to tell patients, but I think it's important because, there are some patients that actually have to have a catheter in their neck. And so those are things that, patients need to prepare for. Some of the side effects of the lymphodepletion can be obviously that the blood counts go down. That's actually kind of the goal. There is some nausea and vomiting, some diarrhea. Those are all very well managed, it seems, with some of the medications that we give as pre-medication. Fatigue that kind of comes from the counts going down. And then one of the other side effects that is commonly reported is cystitis, which is an inflammation of the bladder, but making sure that the patients are very well hydrated and making sure that we empty our bladder frequently can sometimes help with that. So when it comes down to the actual TIL infusion, this happens once the lymphodepletion has been achieved. There will be some pre-medications given. Usually it's some type of antihistamine and some acetaminophen. The actual infusion of the TIL product takes about 90 minutes, and it will be anywhere from 1 to 4 bags, depending on the product that is made. It's very uncommon actually to have side effects during the infusion of TIL therapy. It only happens in about or less than 4% of patients. There is something that is called cytokine release syndrome. It can happen. It's actually kind of like a global histamine rush where patients have changes in blood pressure, sometimes shortness of breath, some flushing. It can be a very serious reaction, but this happens very rarely here. In terms of the IL-2 therapy, this actually happens after the TIL infusion. Normally, patients will get 6 doses. It's given every 8 to 12 hours IV. As someone who has experienced IL-2 as a therapy, this is actually a much more easily tolerated form of IL-2. It's not the full bore dosing. You will get anywhere from maybe 3 to 6 doses over 3 days. It depends on really how you tolerate it. Sometimes we have to stop early if there are significant adverse events. We've seen, a lot of third spacing. So patients, I think the most I've ever seen someone gain fluid retention is about 25 pounds. And that fluid retention can happen, in your legs, in your arms. It can happen around your lungs. That's called pulmonary edema. It can happen in your brain. That's called cerebral edema. And if those types of things happen, they're a lot more serious. But that's why we give this product inpatient. And it's the reason, folks that are on the oncology floor are very well trained to handle these types of toxicities. But some of the other things, it can cause hypotension. So that's why they give fluids. And that's why renal function is super important. It can cause some racing heart or tachycardia. It can cause some nausea and vomiting. We've seen rashes develop. It can decrease urine production. It can cause fever and chills and muscle aches. But that's all due to the way that we're increasing your immune response and try to boost the support of these T cells. Some of the things that happen then after treatment is that because of the lymphodepletion, we will find that most patients will require support for prophylaxis to avoid infection. So when we drop counts to give the TIL product, it makes the patient more susceptible for fungal infections and bacterial infections. And so there are drugs that we give to help prevent that. So antibiotics is one of them. They should be started as soon as the onset of the low white blood count occurs, or when the ANC, which is the amount of neutrophils, drops below 500. We typically give Bactrim. It's typically given 3 times per week, and it should continue until the ANC is recovered. There are recommendations that state that it should be given for 3 to 9 weeks. But honestly, I think that we just in our institution, and that's very institution specific, give it until the counts recover. There are also antivirals. The typical antivirals that we use are acyclovir or valacyclovir. And then antifungals are typically fluconazole. And again, these patients will stay on these medications until their counts recover. So when do I get to leave the hospital? That's the number one question that patients ask. So patients are discharged when not only their counts recover from a hematologic perspective, they are, their hemoglobin and hematocrit are at a level that they feel safe. Platelets are a level that the inpatient team feels are safe. But also once they recover from some of those IL-2 toxicities. So, if a patient is having a lot of shortness of breath and has an oxygen requirement, we really don't want to discharge them home until they, are able to sustain a good oxygen saturation and the team feels safe. This is typically about 14 days after the TIL infusion. I will say that we've had a few patients that have been discharged sooner than that, but certainly 14 days is a good starting point. Some of the things that patients need post-discharge, however, we've had to infuse platelets, sometimes red blood cells for the hemoglobin and hematocrit support, and sometimes hydration. So those are things to kind of look for when you go home. There are some really great resources that Iovance provides on their website. There are links for financial assistance, which include copay assistance for patients that don't have insurance. There's also some support for transportation and housing assistance, because since there are specialized centers throughout the country that are trained and are certified in giving this tumor-infiltrating lymphocyte therapy, sometimes patients have to come from a far distance. And so that becomes a huge issue for patients that maybe live several hours away. And then you can also call the case manager, and I put the telephone number here on the slides, because they can also help you with additional resources that may be needed. But all of this can be found on Iovance's website. It's iovancecares.com. And that is it.